So we discuss anatomy of venous system, and it is very extensive topic. So we will limit our discussion on venous anatomy on applied aspect. So applied aspect of the venous anatomy related to CCF, vein of Galen malformation, and idiopathic intracranial hypertension. Because previously I prepared whole of the venous system and I found that if I discuss this, I am not able to discuss cases and applied aspect. So I am discussing the venous anatomy related to this disorder only. Fine. So we start with the case. 40-year male, and patient has chemosis on the left side. There was no diplopia, no restriction of extraocular movements, and no bruise. So we can understand if the patient present with only with the chemosis, I think it is very difficult to say which type of disease it is, and usually they refer to one ophthalmologist to other ophthalmologist, and it is diagnosed as a chronic conjunctivitis. On coxing, patient told there is a mild head injury 5 months back, but it was very mild, and on repeated asking, patient tell there is some injury. This is MR, and it shows some prominent venous channel here, and this is the DSA. So this is the external carotid system, and this is middle meningeal artery, and there is a venous pouch here, and it is a superior ophthalmic vein, and it is an inferior ophthalmic vein. More closer view, so it is a middle meningeal artery. It has a venous pouch, venous connection at the cavernous sinus, and superior ophthalmic vein and inferior ophthalmic vein. So we can understand possibly it is a carotid-cavernous fistula. This is the AP view. This is the middle meningeal artery. This is the fistula location, and this is the prominent superior ophthalmic vein. This is the left side internal carotid artery injection. So there is no supply from the internal carotid artery system. So it is not direct type of fistula. It is only indirect type of fistula. So it is type C fistula. So what is type C fistula? When the dural artery is supplied to the cavernous sinus, we say it is a type C carotid cavernous fistula. To treating it, we can go either through the arterial approach, through the middle meningeal artery, or we can go through the venous approach, through the ophthalmic vein. So for the approach of treatment, we will discuss about the CCF, classification of CCF, and cavernous sinus anatomy and its connections. So we know that carotid-cavernous fistula is there is a rent in the cavernous segment of ICA, and it directly communicates with the cavernous sinus. Or sometimes it may be indirect connection, at was in previous case. So there may be connection from the dural branch of the external carotid artery to the cavernous sinus. That is type C. The classical triad of CCF is chemosis, proptosis, bruise, and sometimes tinnitus. And you can see there is a prominent veins on the eyelid. So these are very common findings in case of CCF. This is the classical Barrow's classification, type A. So there is a direct connection between the cavernous segment of ICA to the cavernous sinus. Mostly it is a traumatic, and 90% of carotid-cavernous fistula are direct type because of trauma. Then type B, if the dual branch of the internal carotid artery is supplying to the cavernous sinus, it is type B. If dual branch of external carotid artery is supplying, it is called type C. And type D is if the dual branch of ICA and dual branch of ECA is supplying to the cavernous sinus, that is called type D fistula. So coming to the cavernous sinus anatomy, it is lateral to the pituitary fossa and sphenoid sinus. It is a heavily tabulated and compartmentalized venous spaces. So you can see there is a multiple venous compartment in the cavernous sinus. And this is the C4 segment of the carotid artery. This is the sixth canine now. Just near it is a sympathetic chain. So sometimes there may be Horner syndrome. And on wall, we have third, fourth, and fifth V1, V2 canine divisions. So this is the cavernous sinus. So it extends from the superior orbital fissure up to the petrous apex. So anteriorly there is a superior orbital fissure, and posteriorly there is a petrous apex. So this is the cavernous sinus. Anteriorly there is a superior ophthalmic vein, and this is the sphenoparietal sinus. Laterally there is a pterygoid plexus, and medially there is an intercavernous connection. So there is a intercavernous sinus. So there is a communication between one cavernous sinus to other cavernous sinus through this connection. And posteriorly, There is a superior petrosal sinus, which ultimately drain into the sigmoid transverse sinus junction. Inferior petrosal sinus will drain into the intrajugular vein, and then we have the clivus venous plexus. So these are the posterior. Superior petrosal sinus, inferior petrosal sinus, and the clival venous plexus. So this is the diagram which shows complete drainage of the cavernous sinus. So this is the cavernous sinus. Here we have the superior ophthalmic vein. It is the inferior ophthalmic vein. This is called angular vein. Then we have the facial vein, and this is the facial vein arising from the intrajugular artery. Then we have the superior petrosal sinus, which is connected to the sigmoid transverse sinus junction. Then we have inferior petrosal sinus, which is directly open into the intrajugular vein. And then we have two more sinuses, that is clival venous plexus, and this is clival venous plexus and the pterygoid venous plexus. So these are the all communication of the cavernous sinus. Along with this, superiorly, it's connected to the superficial middle cerebral vein to the uncal vein. So this is the angiogram. This is the cavernous sinus. This is the superior petrosal sinus. This is inferior petrosal sinus draining to the intrajugular vein. This is clival venous plexus. This is superior ophthalmic vein, and this is sphenoparietal sinus. AP view. So this is cavernous sinus. These are the intercavernous connection. This is the superior petrosal sinus. This is the inferior petrosal sinus. This is superior ophthalmic vein. This is pterygoid venous plexus. This is the clival venous plexus, and this is intrajugular vein. Inferior petrosal sinus draining into the intrajugular vein. So this is the catheter in the right inferior petrosal sinus. This is the catheter in the left inferior petrosal sinus. That is our to take the roadmap. It is into the internal carotid artery on the right side, and we can see this nicely. We can see the cavernous sinus. So this is the cavernous sinus on the one side. This is the cavernous sinus on the opposite side, and we can see two connection, intercavernous connection, and this is the inferior petrosal sinus. Same patient. This is our catheter in the inferior petrosal sinus, in the intrajugular vein. This is inferior petrosal sinus, and we can see this is the cavernous sinus. This is the pterygoid venous plexus. This is superior ophthalmic vein. This is the angular vein, and these are the facial vein. So best way to understand the anatomy of the cavernous sinus, do inferior petrosal sinus sampling in case of Crisenoid disease. And as we discussed, it is also important to understand that the cavernous sinus segment, the cavernous ICA has the two important branches, meningo-hypophyseal trunk and inferior lateral trunk. Because when there is a CCF, either rent occur at the posterior genu near meningo-hypophyseal trunk or at the origin of the inferior lateral trunk. So coming to our case, indirect fistula supplied by the middle meningeal artery, type C fistula, artery approach or venous approach. So we thought we will go to the artery approach. So we prefer to go to the artery approach rather than venous approach. So this is our guiding catheter. This is a microcatheter in the venous pouch. This is the superior ophthalmic vein, inferior ophthalmic vein, and this is the glue cast here in this pouch. Right reflex in the middle meningeal artery. This is the AP view. This is the glue cast here, and you can see that fistula is no more filling. So this is pre and post the fistula completely subsided. Pre and post AP view, fistula is no more visible. So there is a pre image and there is the post images. After 3 months, patient chemosis completely subsided. Another case, very rare case, because CCF developing is as of 6 months. There's only one case in literature has been described of CCF in 6 months, and in this case they have not done any intervention because patient is not having any visual problem. It was more cosmetic reason, but in this case patient was having visual problem because I was completely shut down because of so much proptosis, so much lid edema rather. But there was no chemosis and there was no history of trauma. So this is the CT angio images, and we can see there's a very prominent superior ophthalmic vein. We can see there's a prominent superior ophthalmic vein here. This is the CT angio. This is the cavernous segment of ICA, and we can see there's a prominent superior ophthalmic vein here. So it is case of CCF. So performing DSA at 6 months is really challenging, but yes, we have to do. So this is carotid injection, and we can see there is a filling of the superior vein. In the delayed phase, we can see angular vein and the facial vein and the interjugular vein. This is AP view, and we can find there is a prominent superior vein, and there is a cavernous sinus here. This is the delayed phase. And external carotid injection does not show any fistulous connection. So it was direct type of CCF in young patient. So again, either we can approach to the arterial approach, or we can go to the venous approach to the angular or superior vein. So it may be arterial approach or it may be venous approach. So again, we usually preferred arterial approach here. So we went with the microcatheter, and now you can see the fistula was here towards the anterior genu. So it was possibly at the site of origin of inferior lateral trunk. It was not at the posterior genu, it was anteriorly. So it was at origin of inferior lateral trunk. So we went with the microcatheter. There's a lot of loops here. And we placed 3-4 coils to occlude this fistula. So this is pre-images and the post-images. This is the coil mass here. And now the fistula completely disappeared. And we can see ophthalmic artery now. Previously, ophthalmic artery was not visualized. Now we can see the ophthalmic artery here. This is the pre-images and post-images. So fistula is no more filling here. And this is 15 days after. So you can see the child of dispute. So you can see the eye become absolutely normal after 15 days of the closing fistula. And now this eye is functional now. So this is the DSA, right ICA injection, and we can see there's a filling of the cavernous sinus. Possibly it is filling through the some of the dural branches of the ICA. This is the AP view. We can see the filling of the cavernous sinus. No exact fetus is identified, but possibly it is filling from the dural branches of the ICA. This is the left side. Again, we can see the filling of the cavernous sinus. And opposite side, we can see through the intercavernous connection, the opposite cavernous sinus is also filling. When we perform external carotid angiogram, on the right side and the left side, we can see the fistula is filling from the external carotid artery system through the middle meningeal artery and some of the intermedullary artery system. And the left side, it is also filling, more filling from the right side than the left side. So it was filling from the bilateral external carotid system and was filling from the dural branches of the IC on the right side. So it is type D fistula. So type D is the dural branches of the ICA and the dural and the branches of the external carotid system filling this fistula. Now here we plan for the combined approach, arterial as well as venous approach. Because in this case, it is very difficult to go to this dural branch to occlude this cavernous sinus. So we thought that we will go through the inferior petrosal sinus and we will go through the arterial way through the external carotid artery system. So here we went through the inferior petrosal sinus and we also went through the external carotid artery branches to occlude this fistula. So this is the venous approach. This is in the interjugular vein, and then this is a inferior petrosal sinus. It is a cavernous sinus. It is a superior ophthalmic vein, and then we went to the arterial system through the external carotid arteries. So this is the microcatheter in the cavernous sinus through the inferior petrosal sinus, and we place the coil to the right inferior petrosal sinus. And then we place microcatheter in the middle meningeal artery on the right side, middle meningeal artery on the left side. This is the coil mass because we have occluded to the inferior petrosal sinus. So these are the prominent superior and inferior ophthalmic vein. You can see by the microcatheter injection. By microcatheter injection, you can see the prominent superior ophthalmic vein here. So this is after the coiling. Now we can see the cavernous sinus, no more filling here. This is the coil mass here. This is the left side, slight filling of the cavernous sinus. We went through the only right cavernous sinus only, not through the left cavernous sinus. And through the external carotid feeders, we done the particle embolization. So on the right side as well as on the left side. So this is after 45 days, both eyes become absolutely normal. Another case, non-traumatic CCF. Non-traumatic CCF are rare, but I'm seeing mainly non-traumatic CCF, and we'll see 1 or 2 cases of traumatic CCF also. 28-year female, redness in right eye for 7 months. She has tinnitus. For 3.5 months, there was no history of trauma, but there was a history of uterine rupture during the 3rd trimester. And there was a negative family history for the similar illness. So this is called Becton score for hypermobility of joint. So this patient have 6 score out of 9. So that is called significant score. So you can see there is a hyperextensibility of the little finger, hyperextensibility of the trunk. So patient can stand like this. There is also hyperextensibility of the thumb and the hyperextensibility of the forearm. She was 28-year female, and you can see there was too much hyperelasticity of the skin. And the skin was very, very thin, and you can see the subcutaneous blood vessels below this skin. And there was a easy bruisability of the skin here. This is the CT orbit, and we can see there is a proptosis on the right side and very prominent superior ophthalmic vein on the right side. This is CT angio, markedly directed superior ophthalmic vein. This is MRI, flow wide of the superior ophthalmic vein. This is a renal angiogram. Apparently looks normal, but renal arteries are not looking very nice. They are looking very thin. So you cannot find the very prominent renal artery here, but otherwise aorta was normal. And this is the DSA, Venous type A fistula. There was no supply from external carotid artery feeders. So we can find there is a markedly dilated superior ophthalmic vein, angular vein, and the facial vein. But what is interesting in this case, the fistula was not at the cavernous segment of the ICA, it was at the pitral segment of the ICA. So this is the ipsilateral CCF compression. It is very important to take ipsilateral CCF compression in case of CCF because fistula is very high flow and we are not able to see the rent. So we compress the ipsilateral carotid artery and we take the shoot. So there is no distal flow, only flow is up to here. And this is the pitral segment of ICA and we can see there is a fistula here. The cavernous segment is above here. So fistula is connected in the pitral segment of the ICA rather than in cavernous segment of the ICA. Along with this, on the left side, there is a aneurysm on the petrous ICA. There is an aneurysm on the vertebral artery. So approach of treatment can be arterial or can be venous through the angular or superior ophthalmic vein, through this or through this. So arterial approach can be like this. So we went to the arterial approach. So basically rent was here, rent was not here, rent was in the petrous segment of the ICA because our microcatheter went from petrous segment to the cavernous sinus and fistula was completely occluded. So this is after 2 months. Now we can see there is no more chemosis here, mild prominent blood vessels, but chemosis has subsided. And this is follow-up CT angio. There is no carotid-cavernous fistula, but you can see the vessels are very, very dysplastic. So this was case of Ehlers-Danlos syndrome, which is group of inherited connective tissue disorders, which is characterized by joint hypermobility, skin hyperextensibility, and tissue fragility. So this was a rare case because patient has CCF and multiple aneurysm. But what is more important, I think previous speaker had discussed about mandibulovidian artery, which arises from the petrous segment. So possibly the rent was at mandibulovidian artery, which is filling this fistula because there is no filling from the cavernous sinus, it is filling from the petrous segment. So possibly there is tear in the mandibulovidian artery and which is supplying the fistula. Another case, non-traumatic CCF, 35-year female, congestion of the left eye, no proptosis, no extra movement restriction, and there is trauma. And it is 2014. So this is markedly dilated cavernous sinus and markedly dilated venous system. We will have a zoom view. This is the left carotid artery view. We can see there is a fistula, and there is no flow in the MCA or ACA. There is no integrate flow. All blood is still into the venous fistula. So more zoom view. So this is dilated cavernous sinus. This is superior ophthalmic vein. This is superior petrosal sinus. And what you see, there is a marked cortical venous reflex. So there is not a venous congestion, and there may be some venous aneurysm-like kind of thing. And there is a drainage superiorly into the sphenoparietal sinus. And again, there is a venous congestion here. So there is a marked venous congestion, and these patients likely to have intracranial hemorrhage. CCF rarely have intracranial hemorrhage, but when there is a cortical venous reflex like this, these patients may develop intracranial hemorrhage. So treatment, again, arterial approach or through the superior ophthalmic vein. So you can go through this or you can go through this. So we opted as usual arterial approach, and at the time we are using balloon, detachable balloon by BART. So this is first balloon, fistula was not occluded. So we use second balloon and the fistula was completely occluded. So this is pre-image and this is the post-image. Fistula is completely occluded. Now we can see flow in the middle cerebral artery and the anterior cerebral artery. AP view, pre and post, you can see very good flow in the MC and AC, which was not visible here. And this is the balloon here. So these are the two detachable balloons here, which close the fistula. Now these balloons are not available. So this is the opposite side view, and the fistula is not filled. This is a opposite flow by the cross compression. Now this fistula is not more filling, and there is no cross flow here. And the vertebral injection also shows there is no filling of the fistula through the PCOM. So we use these two balloons, gold ball balloon 4 and gold ball 3 of various sizes. This is after 2 days, the chemosis completely subsided. After 6 months follow-up, the chemosis was not there. But the story does not end here. After 4 years, patient came, and now she has chemosis on the right side. Previously on the left side, now she has chemosis on the right side. And now you can see the CT angio, how the vessels are dysplastic. Very dysplastic vessels. So possibly the reason for recurrence is this dysplastic vessel, which was not so visible on the previously CT angio in 2014. And you can see there's a classical beaded appearance, which is found in fibromuscular dysplasia. So this is type A type of fibromuscular dysplasia. You can have various variety of fibromuscular dysplasia. So it was a classical beaded appearance of the fibromuscular dysplasia. Now this is DSA in 2018. You can see there's marked dysplastic vessels, some venous aneurysms, markedly dilated cavernous sinus. Markedly dilated cavernous sinus, sphenoparietal sinus. Again, there's a lot of congestion of the vein here. Delayed phase, you can see the marked congestion. This is a petrosal sinus, superior petrosal sinus, inferior petrosal sinus, and there's a marked venous congestion. So this is on the left side angiogram, and we can see we were occluded the fistula with the balloon on the left side, and it was remain occluded. The problem with the balloon, it said that over the year they deflate, but luckily in this case, the left side fistula was occluded, but right side was filling. And the right external angiogram shows there is some filling from the external carotid artery branches. So there was a marked cortical venous reflex, and we thought that we would treat this patient. Patient did not agree for the treatment. She went home, and after 1 month we contacted her, and attendant told that she is no more. So possibly she bled. So she went home and did not came for the second treatment because possibly she bled because of this cortical venous reflex. Another case, interesting case of CCF, 50-year female, history of trauma, and you can see marked proptosis here. She is not able to open her eye at all. This is CT scan, you can see there's a proptosis here, marked proptosis here. You can see the vessels are prominent in the right orbit. And it was dual hole CCF. So fistula has two openings here. One hole was here and another hole was here. And both holes were interconnected. So both are interconnected. These venous pouch both were interconnected. We can negotiate our microcatheter here and we can negotiate our microcatheter here also. But first we went through this hole. So we have two holes here. And this is the ophthalmic vein here. So luckily, with one hole, the coil went to another venous pouch, and we can occlude both the venous pouch. So you can see one coil march here, another coil march here, and we can occlude the fistula completely. Then coming to CCF, then we will go to the vein of Galen malformation. So coming to the case, and then we discuss the embryology of the vein of Galen malformation. So 29 days old child with marked hydrocephalus. This is dilated vein of Galen, and we can see there is obstructive hydrocephalus. This is the CT angio, so markedly dilated vein of Galen, and you can see there is a stenosis of the sinus, and here it is called falcine sinus, not a straight sinus, falcine sinus. Usually the straight sinus is rudimentary in these cases. So there is a markedly dilated cavernous sinus, and there is a stenosis between the vein of Galen and the falcine sinus. This is the right intercarotid artery injection, and what we can see through the PCOM, opposite side, this fistula is vein of Galen malformation. We can see here on the right intercarotid artery injection, AP view and lateral view. You can see vessels are very, very thinned out in 29 days side. This is the venous phase of right IC injection. We can see all the contrast is stating in this pouch, and hardly any venous sinuses are visible because all the contrast is going into this pouch only. This is the left intercarotid artery injection, and you can see through the PCOM, PCA, this fistula is free. There is a huge fistula here. This is the left ICA venous field. So this is vein of Galen malformation. You can see there is some stenosis here, and there is a falcine sinus. Left vertebral artery injection. This is the PCA, and the posterior coronary artery is supplying to this fistula. And this is a mural type. So basically, we have two types of vein of Galen malformation: mural and choroidal. We will see what are they. So we have to plan our treatment. So before that, planning for the treatment, we have to understand what is the persistent embryonic prosencephalic vein of Markowski, what is vein of Galen malformation, and what is vein of Galen dilatation. So we have to differentiate it is a vein of Galen malformation or vein of Galen dilatation, and what is the type of vein of Galen malformation. It is a mural or choroidal. So there's a difference between vein of Galen malformation and vein of Galen dilatation. So vein of Galen malformation is persistent prosencephalic vein. The vein of Galen dilatation is the vein of Galen developed normally, but it is dilated because of the high flow vascular malformation, usually happen in thalamic AFM. So this is not vein of Galen malformation, it is a vein of Galen dilatation. And why it is dilated? Because of the high flow in the vascular malformation. So vein of Galen malformation is two types, mural type and choroidal type. What is the difference between mural and choroidal type? Mural is like high flow fistula, so it is a direct high flow shunt on the wall of the draining vein. The choroidal is like AVM, so it is an interposing arterial network between the feeders and the draining vein. So this is choroidal AVM, and this is choroidal vein of Galen malformation, and this is a mural vein of Galen malformation. The age of presentation of mural is usually in the infant or the later onset. The choroidal is usually in the neonate or early onset. The associated symptom of the mural is milder, they develop hydrocephalus and some neurological symptoms. But in the choroidal, the symptoms are more, and usually they present with the cardiac failure. The endovascular outcome, the less embolization setting is needed, and there is a high probability of achieving complete occlusion. In the choroidal, more embolizing setting is needed, and there is a lower probability of achieving complete occlusion. So overall prognosis is better with the mural type and worse with the choroidal type. So mural type venous Galen malformation occurs in 1/3 of the cases. They receive unilateral or bilateral supply, and predominantly they receive supply from the posterior choroidal artery only, and they drain into the dilated posencephalic vein. Outlet obstruction is quite common. So mostly it is a fistulous type of connections between the posterior choroidal artery and the persistent posencephalic vein. But the choroidal type of vascular malformation are more common in 2/3 of the cases, and they have abundant blood supply like this. They have supply from the anterochoroidal artery, they have supply from the posterior choroidal artery, they have supply from the perichoroidal artery, and they may have supply from the subappendicular branches of the thalamo-perforating artery. So neonates venous Galen malformation present with the high cardiac output failure, tachycardia, respiratory distress, sinuses, and hydrocephalus. It is important to treat these type of malformations because patient may have obstructive hydrocephalus followed by periventricular leukomalacia, atrophy of adjacent structures. There may be cortical laminar necrosis and secondary atrophy because of steel phenomena, ischemia, venous thrombosis, or hemorrhage. So if you don't treat at proper time, then patient may develop cortical atrophy and the child become permanently disabled. So coming back to our case, it was a mural type of venous Galen malformation because it was supplied from the posterior choroidal artery. So this is our microcatheter in the posterior choroidal artery, the fistula. They are very high flow fistula. We try to place coils. That's why we can have some engagement of the glue, but unluckily the coils was flying like anything, and we have fear that possibly if we detach, they may go to the pulmonary circulation. So ultimately we did not place any coil, and thus we placed high concentration glue. So this is the angiogram after 90% of glue. There is a stagnation or there is a diminished flow in the venous system, but its fistula was still filling. Then we injected 75% glue again, and then we have completely occluded this fistula. And now we can see, previously there was no artery system was visualized. Now the fistula has gone, and you can see the small ACA, MCA, and other branches of the. This is the vertebral artery. So we can see flow into the antegrade branches. This is the this is the vertebral injection, and we can see there's a flow in the PCA. And all vessels are very thinned out. So this is pre and this is post. So previously all contrast was stagnating into this venous Galen malformation. Now we can see the venous system has appeared. This is the glue cast here. This is the glue cast. This is right ICA injection, pre and post. So now we can see this fistula has disappeared. This prominent vessels was prominent here. Now it has regressed now. This is the pre and post. Previously, the venous system was not visualized. Now we can see. This arterial system was not very well visualized. There's the arterial system as well as now we can see the venous system very nicely. So previously the venous system was not very clearly seen. Now we can see the veins very clearly now. And this is on the left side, pre and post. Now we can see vessels very clearly. And this is the left ICA venous phase. Again, you can see the venous system on the left side. So this is pre-embolization CT and the post-embolization CT after 5 days. Now you can see this venous Galen malformation has completely disappeared. There was a significant hydrocephalus, and ultimately the VP shunt was done. Another case. Now this is 7-month-old child, hydrocephalus. Again, mural type of the venous Galen malformation, supply from the posterior choroidal artery. This is internal carotid artery injection, and there was no supply from the antecorridor artery, no supply from the pericorridor artery. So it was not corridor type of vein of Galen malformation. It was a mural type of vein of Galen malformation. So treatment plan remains same. So this is our microcatheter here, and this is the we embolize with the 75% of the glue, high concentration glue here. So this is the pre and post. So now this fistula has disappeared. Now we can see the both PCA. You can see both superior cerebral artery, which was not visualized because of the steel philuma. This is post-embolization vertebral artery source. Now coming to the idiopathic intracranial hypertension. This is the third topic. So we start with the case. 20-year male, and he is not obese. So we know that idiopathic intracranial hypertension is usually developed in obese patients, and usually they are females, but it was a 20-year male, non-obese patient developed bilateral grade 3 papilloma, left 6 cranial palsy. There was a significant picture loss, and the CSF manometry shows the CSF pressure was 420, so very high CSF pressure. This is the MR images. We can see there's some flattening of the globe, and we can see there's a CSF space around the optic nerve has dilated. So these are the signs of the idiopathic intracranial hypertension. So these are the DSA images, and we can see there's a narrowing of the right transverse sinus. There is no filling of the left transverse sinus, but there is a distal filling of the interjugular vein and the transverse sinus, but it was not filling from here. And in lateral view, you can see there is a small segment of focal stenosis here corresponding to this segment. So what should do? So should we plan for venous sinus stenting? What is the mechanism for elevation of idiopathic intracranial pressure in the case of IIH? And what is the anatomic variability of the trochlear hierophili or sinus confluence and transverse sinus? So what is the mechanism for elevation of intracranial pressure in patient with IIH? Usually it is a centripetal obesity, although it was not in our case, but we know that it's common in obese patient, and most important treatment is reduce the weight. So because of central adiposity, there is a dysfunction of, and there is a androgen excess. The androgen excess produce increased CSF production from the choroid plexus. So either it can be increased CSF production from the choroid plexus, or it can be reduced CSF reabsorption because of venous outflow obstruction. Or the new theory came about this IIH is the lymphatic dysfunction. Now a lot of neurological disease has been explained by this lymphatic dysfunction. Even the normal pressure hydrocephalus, the lymphatic system theory has come in this. So even the idiopathic intracranial hypertension, the lymphatic system is supposed to be responsible for this. So what is the lymphatic system? The lymphatic system is along the artery and the vein, there is a perivascular space. So this perivascular space has lymphatic system, and this space represents the direct connection between the cerebral vascular system and the CSF. So if there is an impaired lymphatic system, we know that in the brain there is no lymphatic system. There is a, now they have discovered lymphatic system. So if there is an impaired lymphatic system, there is a decreased absorption of CSF, and which may result into idiopathic intracranial hypertension. At the same time, we must understand, because if we are planning for the venous sinus stenting, we must understand the various anomalies at the torcular heterophyli. So around 50% of the cases, the transverse sinus and the right and left both are dominant. In 25% of the cases, only the right transverse sinus is dominant, left is non-dominant. In 10% of cases, left can be dominant and right can be non-dominant. In some of the cases, this may be the seen as was in our case. So there is a hypoplasia or aplasia of the sinus on the left side. And then maybe there may be various permutation and combination of the abnormality at the confluence of the sinus or the transverse sinus. So we were dealing with this type of sinus abnormality. So this was in our case, left transverse sinus was not filling, but there was a distal filling. So why there is distal filling? This distal filling is through the vein of labii and vein of the Tollard. So the vein of labii and the Tollard are reconstituting the sinus, and there is a distal filling in the transverse sinus and the interjugular vein. Just like our case, right transverse sinus, there is a stenosis here, and the left transverse sinus not visible, but you can see this is the vein of labii here, and this is the vein of Tollard, which is forming the part of the transverse sinus and this interjugular vein. So if you plan for the stenting in case of IH, we have to do the pressure gradient measurement. So these are the pressure gradient in our case. This is the confluence of sinus. This is the stenotic sinus. So proximal to this, the pressure gradient was in superior sagittal sinus. It was 15, 20. It was 17 in the stenoid area, and distal to this it was 8. So there was a pressure gradient out of 9. So anything above 8 is important. Some say it is 10. Our case has pressure gradient of 9. So this was the case. There was a stenosis on the right side. So we can place. If there is a significant pressure gradient, then a stent may be helpful. So this is the stenosis sinus. So we place the wall stent here. So this is the wall stent here, and now we can see the right transverse sinus is very nicely filling here. To demonstrate it is really effective or not, we have done LP on the next day. So on the baseline LP, the pressure was 420. After the stenting, we have done CSF, the pressure become 190. So it shows that pressure significantly came down just after the stenting from 420 to 190. And there was a significant improvement in the visual acuity from 160 to 624 in the left eye. So thanks, and thanks to my team, and thanks to Dr. Rahul and everybody for the patiently listening. Thank you.